So like what Dustin said, this is just on blunt trauma. This is all for blogs from all on the TPPP agency app that everyone has like readily access to. It's really nice just the way he lays out everything. So you're gonna see it's pretty identical. I just have a lot of photos and things to make it a little bit more fun.
Speak up a little bit.
Okay. And you're going to see a lot of like repetitive. So after I go through like the first couple slides, there's like a protocol that's laid out, and you're going to see that theme throughout all of these different, most of these different presentations of trauma. So this is the overview of the different types of trauma we're going to be covering today. We're beginning with triaging because that's just super important communication with the hospitals that we're taking these patients to. And then like what classifies a mass casualty incident, and then just basics on bleeding control, hemorrhagic shock, and then the different types of trauma affecting the different body areas. And then at the end, I have a few different resources if you're really geeked out about trauma, you can access. So this is just a basic definition about trauma. It's just referring to just really severe damage to a person or persons, creating significant risk of loss of their life, disfigurement or disability, depending on what they're exposed to. The trauma radio reporting, as I've been told, is like incredibly important, and like talking on med control about what age these people are, what if they're minor or major trauma, the gender of the patient, your ETA to the hospital, and then the mechanism of injury to these patients. It's really important to make sure that this basic information is given, and then other information can be given as well. But the TAGEM acronym, that's what I have laid out there. That's going to be the most important information given during the med control radio. And then deciphering between major and intermediate trauma is important. These patients are going to be classified by their age into the three groups: pediatric, geriatric, or adult, and then with the major intermediate level designation. And then I'll talk about the facilities. I know you guys are all very aware of the different facilities in the area, but just considerations when picking the facility if you have the ability to pick the facility. These are the different body regions I'll be covering too with their trauma locations. So the first one I'm going to start with is adult and major. This has a lot, but you're going to see the same theme throughout the different classifications. So adult major is a 16 to 69-year-old individual. They're going to have at least one of these physiologic or anatomic conditions going on. I put up there the GCS scale. Just like something I think about when I'm receiving a patient is like really easy for me is GCS of a 12 or less. That's going to be a moderate brain injury. So they're starting to like not be able to localize the pain. They're not, there's actual like impairment that you can see versus when it's minor, it's kind of hard to see if like they're truly like a minor brain injury or not. But so for a major, they're going to be 12 or less. There's going to be loss of consciousness that you see during transport or while on scene. Like I said, they cannot localize the pain. That's going to be more of like a really severe brain injury. If the patient requires intubation, if they require pneumothorax relief, if their pulse is greater than 120 and they're starting to become hemorrhagic shock signs, which I'll discuss later, that also is a classification, or if their systolic blood pressure is 90 or less and there's an absent radial pulse. Anatomic conditions will include the penetrating trauma to head, neck, or torso. Obviously, really common in like motor vehicle accidents, but can happen with really weird accidents too, like impalement, like off a tree or something. And then where the trauma is, the penetrating trauma is at too. So if it's proximal to the knee or the elbows, there's going to be a lot more neurovascular compromise evident there versus lower extremity. So that's just something to consider. If they have signs and symptoms of spinal cord injury, which I'll discuss later too, and then second or third degree burns that involve more over 10% of the total body surface, which I have diagrams to show as well, or if it involves their face, genitalia, or airway. What flail chest was also another one, and it is like a concept that like I had to like visualize all the time. But it can happen with like different conditions that the patient has been exposed to. But essentially, like when we inspire, our chest goes out. But with these patients, because they have rib fractures, that's what the flail chest is indicating. It's going to be paradoxical to what you expect. So their chest ends up falling in because of those broken ribs. And the more that they breathe in and out, the more of a chance that there's going to be a bleeding issue or a lung impalement or something, and their condition can deteriorate really quickly. So it's just something to consider, and it's a major trauma indication. This was the burn body, the rule of nines that most people know about. I have another diagram with children because it does change a bit. But it's just like the rule of nines. So your arms make up 9% of your body, total body surface. So if a patient's burned from both arms and a little bit more involving the shoulders, they classify as a major indication. Just something to consider. When moving down to an intermediate, this person's GCS is going to be 13 or above. The loss of consciousness has to be witnessed by you for over 5 minutes when you're there. The pulse is greater than 120 like before, but there's no signs of shock at this point. And the respiration rate is either too low or too high at that lower than 10 or above 29 range. Neurovascular collapse signs like that hemorrhagic, they're going to have, this is going to be like spinal or like vascular compromise. And so they're going to have pulses that are leaving, they're exhibiting some signs of paralysis, like not being able to move their limbs or feeling things, or if they're just in a very, very bad pain. And then anatomical conditions that classify in this as well include significant penetrating trauma, but that is controlled. Seatbelt sign is also another one, which I have here too. It indicates like some internal bleeding is going on, but it's still an intermediate trauma versus a major. The biggest difference with pediatric is obviously going to be the age, but their minimal qualifications are going to be a little bit of a higher threshold. You're still going to have the same GCS, the same deterioration during transport or on scene, but respiratory distress and failure or poor perfusion is going to be important to recognize with these patients because it can deteriorate really quickly. Same thing as before with the anatomic conditions, just where the penetration is at. If the burn is involving over 10% of their body surface, if there's signs of spinal cord injury. Respiratory arrest and failure. The biggest thing like is with the air gas, it's hard, I know, on scene to have access or like being able to get gases while you're there or some sort of measurement. But if you can really see the rapid deterioration of these patients. If you have like high CO2 and they're starting to have an increased work of breathing and they're starting to get really tachypnic, that's a really good sign of respiratory failure that's impending. It's going to happen likely. So just to be mindful of these patients is probably going to involve an intubation or something like that. And then signs, physiological indications for these patients as well is going to be stridor, retractions, which you can see like those muscles in the ribs. Those are the muscles that are going to be like visualized when they're retracting. You can see on this baby, like that substernal retraction right there. That's not normal, obviously. So just seeing like those extra accessory muscles being used in the work of breathing is just a good sign that they're having a really difficult time circulating and perfusing their body. Pediatric intermediate is going to mimic adult. Again, the GCS is higher. Loss of consciousness is going to be witnessed by you. And then just where the penetrating trauma is at, it's going to be more distal to the patient's torso. And then the seatbelt sign as well for them. Considerations with these patients is going to be the mechanism of injury. It's like really easy to like when I think of a car accident, I think of like the worst case scenario. And I just imagine if I was out there, I would think that it's like an automatic major trauma. So it's just really important to like not classify them as major or intermediate based on what injury they've experienced. Geriatric is going to be 70 plus or older. Again, it's going to be really similar to the adult and pediatric major classifications. Their GCS is going to be a little bit higher because these patients, they can deteriorate really quick as well. If they required like the intubation, like I said prior, the pneumothorax relief for those hemorrhagic signs, the same anatomical considerations with burns or penetrating trauma, it's gonna all be the same. With these patients, so specifically, if their cause of injury was struck by pedestrian struck by a motor vehicle or falling from any height, they're considered major at this point. But the falling has to have TBI evidence or a history, or suspected rather. Intermediate is going to be the same as prior as well. Anatomic considerations for these patients, it's going to be injuries on 2+ body regions. Again, the seatbelt sign and then abdominal distension. So these are like the local trauma centers that y'all are very aware of. ProMedica Toledo and then St. B's is going to be your 2 level 1s. Special consideration, these are they can take major trauma. I think the biggest thing for me when I was writing this down was for transferring trauma, especially with pregnant patients, they cannot go to UTMC because they cannot monitor the fetal heart rate or their status well, because they don't have access to those resources. So just keeping that in mind. But other special considerations was if there's unsafe or inappropriate transport to a better suited hospital, it's going to affect us in the wintertime usually. If there's transport causing a local EMS resource shortage, no appropriate trauma centers able to receive or provide care without undue delay. I didn't realize patients could request prior transport, but if they are able to request. Burn patients who meet major criteria should be transported to St. B's because they have that burn unit that can take care of them properly if you're able to take them there. Then isolated geriatric hip fractures to be transported to the most close facility for them. But of note, I know you guys all know, just the interventions that would delay transport should not be underdone unless it's airway control as an exception. I know there's a couple other exceptions that you'll make when you're out there because it's, at the end of the day, it's based on your judgment. But the biggest thing that he was saying was just to not delay transport. And then we're going to go into like the separate different types of trauma aspects. So with bleeding control, there's a lot of really great control the bleeds that is held locally that I know. There's the most common signs of full perfusion is going to be those weak distal pulses. If it's either white or blue, showing that there's hypoxia in the distal limb. If there's delayed capillary refill, meaning if you press on like the nail beds, then the pink doesn't come back within 2 seconds, that's considered delay, and then an increased heart rate. And then 1 and 2 are going to be the same with every single thing from here on out. So just making sure the scene is safe, making sure you're maintaining infection control via gloves or whatever to make sure that you're not getting covered in whatever substance is there. And then your ABCs, just airway, breathing, and circulation for these patients. For bleeding control, you're going to apply direct pressure to the wound. You're going to apply pressure dressing. You're going to put a hemostatic agent. I know they have like some clotting things that you can put on there. And then you're going to apply a tourniquet. If you have access to like a cat, that would be really great. But if you don't, you use what you have, like blood pressure cuff or just material that you have. If you could, the indication is to apply it 2 inches proximal to the wound and then overlying, if it's on the arm, the brachial, or if it's on the leg, femoral arteries. And then at this point, obtain vital signs, making sure they're still perfusing well with the pulse ox, monitoring the blood pressure, making sure they're not going to enter into shock. And then if bleeding's under control, the rescued guard is shown in that picture too. What's really cool about them is there's 2 aspects to respiratory, like being perfused properly, and that's oxygen coming in via airbag or nasal cannulas. And then the other aspect of it is pressure, and that's what causes us to spontaneously have air enter our lungs and spontaneously leave. And so what's cool about these devices is they have both considerations in there. It allows for proper pressure as much as it can within the chest, along with that oxygen being properly administered to the patient. So it's really cool device to be able to keep both aspects of respiratory drive within reason. And then if it's necessary and needed, apply the cardiac monitor, the 12 lead, establish vascular access at this point. And every single one is going to be a 1 to 2 large bore, so a 16 gauge or larger. But if it's a geriatric or pediatric patient, I know this is really difficult. So just getting any sort of a line established is great. And then if they have shock signs, you're going to administer a fluid bolus at this point, and then TXA for them, and then contact medical control as well. Hemorrhagic shock. Just want to kind of go over the signs with this. Again, it's that delayed capillary refill. They're starting to become cool, pale, diaphoretic. They just look generally unwell. And then their systolic blood pressure is getting decreased more and more, and their pulse pressure, the difference between the systolic and diastolic pressures are getting smaller and more narrow between the two numbers. And again, check scene safety and follow the ABCs. With hemorrhagic shock, again, pulse oxy, TCO2, if you can get that. And then that rescue guard will be great, especially if the blood pressure is lower than 90 systolic. If bleeding's under control, then you can use these devices. But bleeding is going to be like your #1 priority on top of the ABCs for these patients. Again, apply that 12 lead, establish vascular access. Same thing, fluid bolus, TXA. So the goals for these patients is going to be 90 systolic, but if they have severe head trauma, it's going to be a higher goal than this. So a little bit more aggressive fluid or pressor use based on what the department has access to. Burns, I'm going to go over the different types of burns. What's important for these patients, it's going to be the same exact thing: vitals, 12 lead, rescue guard, the vascular access, the blood pressure considerations. Just trying to doing your best to make sure these patients don't go into shock and recognizing when those signs are starting to happen. And then pain management per the department's protocol. I know each department kind of varies on pain management. This is that graph or picture rather of the pediatric one, because it's a little different with like the legs consideration, and same with toddlers or like young children. The rule of nines, as you can see, is going to be the same with adults, but these are going to be the considerations for the TBSA, the total body surface area that is burned on these patients. Again, over 10% is going to classify these patients as a major trauma patient. So thermal burns, these are going to be the signs of them. You're going to have these blisters that are full of fluid. With these patients, the biggest thing is like removing like clothing that's smoldering, but not ripping off stuff that's like adherent to the patient. And then anything potentially constricting, trying to get off is within reason. And then if the body surface area is going to be greater than 20% on these patients, you're going to cover them with dry dressings, versus if it's less than 20%, then you're going to use cool and wet dressings on these patients. Chemical burns, they do look a bit different depending on obviously the chemical that's they've been exposed to, but they're a little bit more disfiguring. The biggest thing is going to again be removing the clothing and making sure you're safe and exposing yourself to what the patient has been exposed to. You're going to try to decontaminate these patients with like flushing clean water or saline over them, removing constricting items within reason, and then wrapping the burned area in a clean and dry dressing during transport of these patients. And then electrical burns, they also too look a bit different. A special consideration with these is if there's multiple people that have been involved in an electrical burn, you're going to reverse triage these patients, instead identifying the least critical patients that need the least amount of resources. You're going to follow ACLS protocol because of the risk of arrhythmias with these patients. Mobilize a C-spine with these patients too, and then prolonged respiratory support may be necessary. Again, apply the sterile dressings to entry and exit burns. And then that's it. And then again, with the burns, those patients go to V's if at all possible. And then for the next couple slides, it's going to be the traumas based on the body regions that are involved. So with head trauma, I refer to traumatic brain injuries prior. So the TBI signs are going to be the decreased level of consciousness from baseline. They're going to start getting more confused. They're going to have unequal pupils. They're going to have blurred vision. They're not going to be able to really vocalize well what's going on or where they're at. They're just not oriented at all. They might be even having nausea or vomiting, really bad headaches. Again, 1 and 2 are the same with these patients. So high flow oxygen is going to be really important. You want to avoid hypoxia and hypotension with these patients, because once they start heading into hyperventilation, that's going to be impending respiratory failure. It's going to be that sign that their CO2 is going to be going up and their O2 is going down. The non-rebreather mask is going to be used at this time, a 15 liter per minute, if ventilations are effective. If this is not effective and their O2 is not going up, you're going to use that bag mask that I have pictured right there to with O2 at 15 liters with a simple adjunct attached. Ventilation will be at 10 a minute, maintaining the end tidal. The end tidal is the most important, keeping that at 40. And just watching that. If airway compromise and hypoxia persists, this is when we're going to start considering intubation for these patients. And again, just making sure we have waveform capnography for these patients and making sure they're staying at a 40 if you can help it. And then protocol continued. Again, establish vascular access within, try to get those large bores if we can. Aggressive fluid resuscitation if they have signs of shock. Don't wait for hypotension to occur. If they are having other signs of shock, just go ahead with the fluid resuscitation for these patients. It can be either saline or lactate arena, and start with the initial bolus of 1 liter and then 500 mLs as needed after. We're trying to maintain a systolic blood pressure for these patients at 110 to 120, not the 190 that I was referring to earlier. And if they have other things that are going on, like hypoglycemia, just try to correct those if you can, and then apply the cardiac monitor. If signs of herniation, I have in that picture, because in the special considerations, he doesn't want you to hyperventilate in the setting of a suspected herniation. All that herniation means is the brain is like going down the canal, and it's going to start causing the bottom part of the brain to start getting compressed. And so that respiratory drive and those internal drives that make our bodies have those natural set points is going to start deteriorating. So these patients will have those fixed pupils. They'll have erratic breathing because the center is just knocked out from that compression. They're going to have really bad headaches and vomiting, and respiratory irregularities, like I said. So just try not to hyperventilate these patients, and giving them more oxygen than needed. And then analgesics and sedation. And these patients should be cut to a quarter of what you normally would give for the patient based on their habitus, because you don't want to knock out what is left of their respiratory drive. So it's just something to consider as well. Face and neck trauma, it's going to be the same as before: vital signs, cardiac monitor, vascular access, and maintaining that blood pressure. You're going to give these patients as well a fluid bolus of 20 mLs per kg and then TXA. These are different types of injuries with the face. So with one's trauma that involves the eyes, if you have access to an eye shield, that would be great to use in these conditions. You're just gonna, if they have an object, it's important to stabilize it. A bull's teeth should be kept moist in a saline soap gauze if possible as well. And don't attempt to stop the free drainage from the ears and nose. Just let it, I mean, keep your stuff clean, but like, just don't prevent it from like stuff their ears or their nose, unless it's like a crazy nosebleed or something, but this kind of free drainage, not to stop. Tetracaine is what I have up there. It's a topical anesthetic that can be used for non-penetrating eye injuries. And then consider eye irrigation with normal saline if they've been exposed to chemicals or a foreign body with copious amounts of fluid. Pain management per your protocol as well in these patients. Chest trauma, same thing, vitals, 12 lead. If you suspect attention pneumothorax, if you can't, paramedics decompress as per needle thoracentesis protocol. I just had a picture of like the mid-scapular line just for reference up here too. If there's open wounds to the chest, make sure you cover with an occlusive dressing. If there's a sign of a flail segment, an intubation with manual ventilation and pain control is going to be indicated at this time. And again, stabilize the impaled object to the patient. And then at this point, you can go ahead with your vascular access, your blood pressure monitoring, your TXA, your fluid bolus, and then pain management. Abdominal trauma, again, is going to be the same as before. The consideration with this is going to be for penetrating injuries, you're going to cover up the open wound and eviscerate with moist saline gauze. The impaled object should also be stabilized in the position that they were found in. And then again, pain management for these patients. Spinal trauma, C-spine precautions, signs of spinal trauma, pretty straightforward. Paralysis, weakness, numbness, tingling for these patients. Systolic blood pressure. If there's signs of shock coming in or hyperperfusion, you're going to want to do the rescue guard. This is the first time in the trauma portions that the rescue guard is should be considered. But again, vitals, 12 lead, vascular access, blood pressure, pain management. Pelvic trauma. I know there's like some departments that have access to like pelvic binders, like traditional, like just actual casting for them. I thought this was kind of like a cool picture of a cool way to kind of do like a temporary pelvic binder with the patient's pants. But you're going to want to make sure if there's like a limb length discrepancy or the legs like obviously bent off in a weird way, it's going to be your signs of pelvic trauma. So just making sure it's stable and not moving during transport is going to be huge. Again, so vital signs, 12 lead, vascular access, blood pressure monitoring, TXA, and then pain management. Extremity trauma, I know each department also has different casting devices and different things that they have access to. So you're going to splint as appropriate. I know this one kind of comes with experience with traumas in regards to the extremities. So just splint as you think is your judgment. Monitor these patients' vital signs. These patients can have some serious like internal bleeding and signs of shock. So just monitoring these patients via the 12 lead and the vital signs, just making sure shock isn't setting in. And then again, blood pressure control and pain management for your protocol. And then amputation and MFK, you're going to follow the ABC for each one. Obviously, bleeding is going to be a huge issue with these patients. So determine who is the most appropriate to load and go at this time for like a mass casualty consideration if it's more than one person involved. You're going to stabilize and splint as appropriate. If there's a female fracture, this is a picture of a traction splint. That was kind of cool if you have access to one. You can use it again with a pelvic fracture, an approved device, or the sheet splinting that I showed. And then pulsus extremity should be repositioned to attempt to restore the circulation. So like someone is amputated, but still kind of has the extremity a little bit attached, like at the knee, for example, just making sure it's in like proper anatomical position. Those extremities may be able to be saved later. So just something to consider. Systolic blood pressure is going to be really important in monitoring while you're transporting these patients. Again, 12 lead vascular access, blood pressure monitoring, and then you're going to cover the patient's stump if it is completely removed with a sterile dressing that is moist with saline, and then elevate it as well to keep that blood from leaving the limb. And then the amputated part of it, you're going to also wrap in sterile gauze and moist with saline. And you're going to place, if you have access to a watertight container and on ice, you're going to put that on that. A friend of mine, he's a really big nerd about trauma, and these are his favorite trauma resources that he has access to on Instagram, but they have really cool protocol and everything. Andrew Fisher, the trauma daddy, he has like a lot of really cool videos about, he's a paramedic and a ranger QA, so he just has a lot of really cool like algorithms and things to consider when you're out. North American Rescue is also another educational resource that has free access. And then the NAR doctor is the same physician that's involved with the North American Rescue, but they're all three like really cool Instagram pages that are just have really cool protocol and things to consider, and like new and evolving resources to use. And then deployed medicine is another resource. The TCC guidelines are on there. That's all about trauma critical care. It's just a really cool area of medicine. And you just find like a lot of like military vets and things like that are involved, and it's just really cool. And then I just want to thank you for your time and consider just listening to me ramble. But thank you.